So I think fintech is something that always linked to insurtech and the health tech as well.
Sorry, struggling with my unmute button. I want to turn to Dr. Fida Mehran. You are in Bangladesh, and you really take a health systems approach and a systems approach. And picking up from what Dr. Samila also said, is that we're really talking about the digital transformation of systems, whether your financial system or health system. How do you see this playing out in Bangladesh, and to what extent are you focused on aspects outside of the healthcare system for the healthcare system?
Yeah, so in terms of the digital health aspect and that being part of the health ecosystem, this is in fact not a very well explored or well implemented part of the health system in Bangladesh as of now. So the digital health itself did not really come into light that much until COVID. So when COVID started, we saw a lot of digital health care service delivery options coming up. So there were a lot of private firms that started providing telemedicine and other forms of healthcare through digital means. So even the government, they had a telemedicine hotline for a number of years now, close to 10 years now, but that in fact did not have that much traction until COVID really hit. So, but as you have also shown in the report that the digital literacy and the digital penetration is quite high in Bangladesh. But the thing is the parallel systems, support systems that can make use of that digital literacy has not developed. So both in terms of the financial institutions, the fintech in general, the health comes much later, but even generally fintech as a system has not really developed in Bangladesh that much. I mean, all that we have here, we have a very high level of penetration of mobile financial services. People use that a lot, and both through the online and offline, both processes, there's a high utilization of mobile financial services. But connecting these to the health sector has not really happened. So that's one thing. And on the other side, there are certain regulatory barriers to the fintech platform or the mobile financial system platforms sort of getting into insurtech, if you will. So the insurtech itself is not a very known concept yet. There are some firms that are trying out digital insurance models, but in fact, because of lack of regulations, and also there's a kind of fear among people around insurance. So people don't really trust insurance models yet in Bangladesh. So that also is kind of a socio-cultural barrier around people's adoption. The way we've seen the insurance model be very strongly growing in India, the same has not been true for Bangladesh at all. So the way that Bangladesh can progress in these areas is only by, I would say, developing the primary healthcare sort of infrastructure model and then building on that to bring in sort of value addition services to this. And I guess that would be the way to add on that piece to this. And then obviously those regulatory pieces and those stakeholder engagements will be important.
Yeah, that's interesting because it's really thinking of even as much as we talking, especially ACCESS Health about fintech and digital financial services, that's a mean to the end. That's not the end. The end is actually building up the healthcare systems, making sure healthcare access is available for low and middle income communities. I want to turn to Ms. Dini Rawati. You're from HelloDoc in Indonesia. And for those of you who don't know, Indonesia, I think, has the largest number of fintech unicorns in Southeast Asia. It's really a hotbed of innovation. And of course, HelloDoc being one of the leading companies on digital health innovation. How are you seeing these two sectors come together? And are you also facing challenges in sort of being able to cross over sectors, be it technology and financial services with your work at HelloDoc?
So actually, what you mentioned is correct. Before it's not building insurance.
Sorry, can you speak up a little bit? I think we're having a little bit trouble hearing you.
Okay. The volume is already up, yeah.
Yeah.
So up to the next. So actually, you are right. We are one of the fast-moving country, yeah, in terms of fintech and insurtech and the digital disruption. So basically, in Halodoc, we built a system that can cover everything. So let's say in here in Indonesia, the only focus for the fintech and the insurtech is only on the commercial side. But however, they need a system, a platform that can deliver a digital services. So we complete the whole ecosystem. On the commercial terms, on the commercial side, it is the duty of the insurtech and fintech itself, right? But in terms of delivering the digital services to the end user, they can cooperate with us. So we give fair support, yeah, to everyone in Halodoc system in Indonesia. So that is what happened. So it can come across for the end-to-end journey will be much better.
And I think that's a lot of the value that companies like yours and many like you are bringing to people is that end-to-end journey and really figuring out the whole using digital technology is how do we make the process of accessing healthcare easier, convenient, affordable for everybody. I want to talk to Dr. Pankaj Gupta. You have seen, witnessed, and been at the forefront of a major digital health transformation in India. We're talking about UPIs, UHIs. It's a number of changes in a positive direction are staggering. What is your view on this increasing integration between finance, technology, and healthcare? And how is India perhaps leading the way for the region?
Thanks, Sejal, for having me here. And very interesting question. So let me start by talking a little bit about the acceleration that happened in the pandemic. So whatever we expected will happen in about 10 years' time from a fintech perspective, from a health tech perspective, has already happened in the last 2 years of the pandemic. And then we saw a lot of that happen in terms of adoption of health tech and fintech in the pandemic. It sort of zoomed up, especially in India. Telemedicine, there was a question about telemedicine being used in rural and urban. So, you know, it's there's a lot of usage spike that happened in the pandemic from a telemedicine perspective. In primary care, one, because people could not go to the hospitals, to the clinics and all that, but also it made it more convenient to sort of render the services and for the patients to consume the services from wherever they were. And then, you know, so it is sort of a combination of health tech and fintech that came handy. Because if you just provide the telemedicine service, but then there is no financial component to it, then what happens is who's going to collect the money and who's going to pay for those services? Now, the good part was that India was already having a very robust fintech ecosystem that was thriving, and then that, you know, came handy when telemedicine was being used. And there became a model for collecting all the payments that were associated. So there was a business model that came into being, not just, you know, telemedicine as a service for the rural India, so to say, or for the primary care, so to say. It was also supported by policy and standards from the government. So government stepped in with you know, setting up the standards, policy, and the government departments for supporting the fintech and the health tech sort of adoption. And not just that, also on the universal health coverage, where there were a whole lot of policy changes that were done to support the insurance side, the health finance side, to come in and start, you know, doing the work hand in hand with the health tech and fintech. There's another component that happened on the you know, market side. So we saw a complete new set of aggregators emerge in the market, and these were, you know, pharmacy, lab, and teleconsult combinations. I can name a few like Tata 1mg, Pharmeasy, Geo NetMeds, Care Expert, Apollo 24/7, Flipkart's Sasta Sundar, Amazon Pharmacy, and so on and so forth. So all of these emerged in the last about 2 to 3 years, and they have the telemedicine component, they have the lab component, and they have the pharmacy component. They're pretty much covering the entire primary care for areas where there was no service available, or there was an optimization that was possible in urban areas. So they've brought in that, and they're very aggressive in terms of pricing. So they are giving run for the money, for the physical labs and clinics. So in the last about 6-8 months, we've seen the physical labs and clinics having lost value, anything between 40 to 50% of their market value. That's because of the aggressive pricing coming from the aggregators. And these all aggregators are based on technology. So technology being the backbone, they have the financial component built in, they have the telemedicine component, and not just that, they also have the lab and the pharmacy component built in. So it covers the entire 360-degree journey. So what is left is only the referrals to secondary care and tertiary care wherever required. So they are able to do an early intervention for the disease management and so on and so forth. Two more things that I would like to mention. One is the vaccination drive that was done by the government of India that sort of helped the country come out of COVID. And that was based on a technology platform called Aragya Setu and CoWIN, which was, it's not exactly telemedicine, but then it's a technology platform that helped vaccinate 2 billion plus doses of vaccines. And the vaccine itself was a bioinformatic vaccine. It was sort of developed indigenously. If you were to do the vaccine development the traditional way, it would have taken 10 years plus, but we got the vaccine in under a year. That's because technology played a vital role. So, so all of these things, when you put it together and you look at the way the government has played a vital role in enabling the health tech to be rolled out to the entire outpatient setup, that's commendable. So I'll stop there and hand it over back to you.
Thank you, Dr. Pankaj. I think your remarks on telemedicine makes an excellent segue for Ms. Pragati, who is from DocoSan in Vietnam. And I think if you could maybe comment a little bit about that, one, telemedicine as sort of a new face of primary healthcare, its integration to financial services. How is reimbursement happening in Vietnam for telemedicine? And then maybe the question from the audience, from Sachin, on how is telemedicine being adopted in rural areas of Vietnam? So you can take it in any order, but we would love to hear your comments.
Thanks for the questions and thank you for having me. So, I mean, at DocoSan, especially, when COVID happened, so that was kind of like an impetus to pivot the health-seeking behavior of Vietnamese population that was mostly offline to online. And that was also an interesting time when DocoSan was born, which was in the middle of pandemic, sometime around April 2020. So at that point in time, we were offering marketplace solution, which is basically helping patients connect to the right providers. But then we started seeing that there were some access gaps because suddenly you have these health systems which became incapacitated because of COVID, and people were not able to go to the providers. So then launching telemedicine services, which the team built in-house, we provided those services free of cost to our entire provider network. And that sort of enabled the digital, access to the healthcare and drove it basically. And when it comes to what other bundling that we can offer when it comes to telemedicine, I think what DocoSan is trying to do is complete the patient journey, pretty much to what Dr. Pankaj Gupta emphasized through what is happening in Indian health system space. So here, You can have like telemedicine, which can be bundled with diagnostic recommendations. And by that, I mean, you have a telemedicine consultation and then doctor consults and gives you recommendation of certain lab testing, which a patient can get done, which is followed up by another consultation. Or it can also be like visiting an in-house, going in person and going for an in-person examination for a complex health cases. So whatever may be the patient journey, if you have like, if you have these different services, and if you include different but transparent and, different payment modalities, that kind of offers the much needed financial protection to these patients. And, the barrier of, the not having these financial protection is often the barrier to the health seeking behavior of such emerging markets. So, how do we scale these services is basically by forging the right partnerships. So currently what we are trying to do is, or many other platforms like us, if we look at Vietnam, it's very interesting. It has quite high penetration of smartphone users, but equally high percentage of unbanked population. So then, having mobile payment modalities becomes very necessary for platforms like us. So we have like, ZaloPay and Momo, which is also a unicorn and an e-wallet. Having those payment modalities on platforms like us is equivalent to covering for the hygiene factors. If you don't have them, then you're basically not enabling health access to the population. So that's also how we are bridging the gap. And when it comes to rural, like answering your question on what is the adoption of telemedicine for rural population, for now, it seems like the major drive or impetus is coming from two main cities, basically Ho Chi Minh and Hanoi. And while we are, because it's not just driven by the patient side, of course, there is much needed demand, but also it comes to provider adoption of telemedicine services. So it has to go hand in hand. And I think for now, it's not as, I would say it's growing, but it'll take some time for us to get there.
So Pragati, I actually just want to give you one more question that just came up in the Q&A, and then I will turn to Ms. Dina again, is basically how is the reimbursement landscape for telemedicine changing with COVID? Is the government stepping up? Vietnam has a social health insurance system. Is this coming under potential reimbursement by the government now, or are there discussions in the future? How do you see that shaping up?
So telemedicine is pretty much still in the gray area right now in Vietnam. If we see at the proliferation of the private insurance, it stands at like 7%. Then it becomes interesting, like, how players like health tech players, they can forge partnerships with employers who want to get telemedicine, who want to provide telemedicine for their employees. And in such cases, employees are the ones who are often insured. So then you can argue that, okay, this becomes easy for such a segment. But again, you have a vast majority of people who are only dependent upon some form of government insurance, which is pretty high, but it doesn't cover for telemedicine yet. So I think going forward, there are discussions which are happening, but it pretty much remains. Remains to be seen how it will evolve and how it can become much clearer, because it's still like, yes, digital prescriptions were made legal. It was okay, but still it's not very black and white yet.
Excellent. So Ms. Dina, I want to turn to you because there's been a couple of questions, I think, coming your way. In terms of Halo Doc, I think one is, just picking up on the last point that Ms. Pragati had elaborated on, what is the reimbursement landscape by JKN in Indonesia for telemedicine or other digital health platform providers? Is it reimbursed by JKN, or is the discussions with the authorities going in that direction?
So basically, we in Indonesia, Halodoc support or doing multiple engagement, yeah, with lots of party. One of them is with the government. So, but mostly for all parties, we provide cashless first. Reimbursement is our second focus actually. Yes, people can always reimburse Halodoc services because we create a very clear transaction. We even provide anamnesis and diagnosis into our system. The medicine all are itemized, so can be seen and understand by everyone. We also provide digital prescription and also invoices. But our main focus not to reimbursement part. Yeah, we do cashless even with the government. We are helping the government to provide cashless facility to help the country in a better position during COVID-19. Because we are there, we can, in terms of telemedicine, the most important part is not only the teleconsultation, not only the digital prescription, but how to make sure the patient receives the medicine itself. So we are one of the partners that can make sure the instant delivery is there. As you are aware, Indonesia is a very large country. We have also islands and everything else. So we are building everything from scratch. We make sure it's not just a platform, but something that can also solve the patient points. Which one of them is delivering the pharma itself in the right hand. So when we engage with the insurer, with government, even with direct corporates, we make sure everything is there end to end. They can consult with the doctor, they can receive they can get the e-prescription, they can have, we find them the correct pharmacy, and then we make sure the pharmacy can deliver the medicine within 60 minutes up to wherever the patient locations are. So that is how we build our telemedicine. Of course, our first contact is our end user, and now since we are already have like a 20 million transactions per month, it is much more easier for us to tap in with the insurer or other corporates and even with the government. So that is how we engage and transform all of the digital acceleration in Indonesia. We solve the patient points actually. We built a system that is very customer focused instead of only the partners focused. Yeah. Customer focus, of course, is the end user itself, the patient.
Ms. Dini, this is really interesting when we look at Halodoc, because Indonesia is made up of thousands and thousands of islands. And when we look about the adoption of telemedicine, the question going back to rural areas, how has Halodoc, where is most of the services concentrated? Is it in Jakarta and the major cities? And are you able to reach rural populations? And if you are moving in a direction, how are you going about to reach the rural segment in Indonesia?
Basically, our services is everywhere. Yeah. To make sure we have 24/7 doctor available, we are engaged with more than 20,000 doctors, private doctors. And then to make sure the pharma or the medicine can be delivered, we also engage with more than 4,000 pharmacies across Indonesia, nationwide, in every island, not just Jakarta. And then we also engage with one of the biggest, one of the unicorn in Indonesia itself, which can support the instant delivery in every island in Indonesia. So basically, we have all of the components. So it is not only works in Jakarta, but also in many islands outside Java itself. we are in Sumatra, we are in Sulawesi, Kalimantan, we are everywhere. Even though it is in rural area. And what if it cannot be reached out by instant delivery? We also provide non-instant delivery. We are using another logistic company partner just to make sure the people can get their medicine within 2 or 3 days after it is prescribed. So that is what we're building in Indonesia. After people see the impact that we deliver to the patient, and not only the effectiveness in curing or treating the most common disease in Indonesia, but we also give a huge impact on the cost itself. Because if you are traveling to the nearest hospital, it might take you a couple of hours in Indonesia, right? And not only that, the doctor cost itself is much more higher. So we do lots of cost setting in Indonesia. So that's why people also love us because of that. They can cost control their medicine necessity without, of course, prevailing the convenience. So they just stay where they are, and we make sure they can get their medicine.
I think
at
that's
the
a
right time.
really interesting point. And I want to go back to Dr. Samila, because I think this really gets to the heart of also why you are here, this financial inclusion agenda. We heard from Ms. Dini about sometimes, and Ms. Pragati, the real innovation is just going cashless and having the cashless transactions and the digital enablement and transfer of money. And what we just heard from Ms. Dini was just even the cost savings, because healthcare being one of those really high expenses that affect the financial health of people. Can you comment just a little bit about where you see the alignment with the financial inclusion agenda with what we are trying to do in getting people healthcare access?
Yeah. So basically, I mean, if you see the country of Sri Lanka, I mean, there are 2 things which you can get in free of charge. First one is health. So anyone in the market can go to any government hospital and take medicine, whatever you want. So the concern is, I mean, how reliable is that, getting the free medicine from rural sector. So in Sri Lanka, if you see the Colombo, or let's say in this Colombo area, you can see many private hospitals, whereas there is no other hospital in other country or parts. So what happened in the country, the underbanked and unbanked sector is almost 50%, since the people who don't have money, who don't have access to banking products, are stagnated, are cornered. So what we did in Sri Lanka recent times, like 2 years back in the COVID-19 pandemic, so we introduced a sandbox, a fintech sandbox, and investor like friendly sandbox, I would say, to enter the Sri Lanka to do digital lending, which is very convenient, which is very fast solution for customers who are not bank or underbanked. I mean, unbanked both. So the recent times, we got the numbers from all these financial lenders, and the surprising to see the people who are in this rural area have access to these financial services now, since it is more convenient to them, and sometimes it's free of charge for certain days. So nowadays we can see people are moving towards this digital transformation ways, such as making appointment through mobile apps. Now we have 3 mobile apps who provide this solution for all customers in Sri Lanka. So nowadays we saw the numbers are increasing, and the demand, I mean, when you see the loan purpose, when you see the analysis of loan purpose, everyone, almost 1/3 of the requests came from medical requirement or pay their medicine bills. So that is something I believe where this fintech is supporting the rural areas, especially for those people who can't access the banking products, which is very, very sad to say, but now I believe we have found a solution for that. And now we can see many investors from European countries are investing money to fintech plus insurtech as well. Sometimes they have product based on the requirements as well. Sometimes they deliver the medicine as a benefit for these customers as well. Whereas you can do within 24 hours. Sometimes clients who cannot come to Colombo can deliver the medicine through courier services. So which are very good signs of combination of fintech and insurtech in the market. And one more important thing is, if you see the Sri Lanka's, the digital transformation strategy from central bank, their roadmap. So they have given the deadlines for all insurance companies to digitalize their platforms, collecting money, collecting premiums, and even though you cannot go and sign documents from a customer, but you are asked to get it done through a mobile app. So I believe Insurance Commission of Sri Lanka and Central Bank now working together to make this efforts more beneficial for customers as well. And the fintech sandbox, fintech facilities are now driving the business to get the insurtech as well in Sri Lanka as well.
Excellent. You mentioned sort of the crucial now linkages between fintech and insurtech, and I want to go back to a comment that Dr. Fida made at the outset in Bangladesh, the trust factor of insurance products in Bangladesh, and that you're not seeing essentially the same acceleration of insurance as in other perhaps neighboring countries. How do you think we can overcome that, Dr. Fida? And do you see a role of even mobile apps, digital wallets, in helping people get more comfortable with the idea of insurance? So I'd love your thoughts on, assessing this for Bangladesh.
No, thank you. So picking up from where I was, and also what Dr. Samila was saying. So that's the kind of situation where we would like to get to. So a situation where there's a widespread sort of adoption and also understanding of the whole process, and sort of building the trust level. So I think this kind of starts from the basic level of ensuring the primary healthcare and having that system in place. So I think what so when we are trying to build that situation, that kind of a platform, that kind of an ecosystem in the country, we have to ensure that we have a very robust primary healthcare system in place. Because if we want to introduce something through mobile apps or digital solutions, it has to stand on something. It has to have some sort of a platform that it can build itself upon. So if you have a robust primary healthcare platform, you have sort of a network where you can kind of get services both from the public sector, from the private sector, irrespective of where you go. Then only then you can kind of try and build value addition services on top of that. So insurance services as it stands now in Bangladesh are entirely the traditional kind of insurance companies telling that we have health insurance for you, you can buy health insurance from us level. Or on the other hand, there are some of the employers that are some progressive employers, they have employer-driven insurance models for their staff. So that's where we are at this point. So what's needed is, in fact, like on one side, building that supply side kind of primary healthcare infrastructure, and on the other hand, sort of building those kind of like the ecosystem, the kind of the payment structures and all that. I mean, both for the payment to the for the services, and also sort of building some of those models around maybe there's been a lot of micro insurance models that have worked in Bangladesh. So piggybacking on those, maybe creating a lot of PPPs and partnerships that are needed. There was a lot of discussion around sandboxing, which is completely an alien concept at this point, because we don't have the necessary basic kind of regulatory structure at this point. But what we can do is, if we can get into PPP models and have the government interested in those areas, then we can sort of depend on newer sort of thought processes like blended finance, for example, and see if we can have development finance, development funding come in and support some of this. That can, because these development fundings and also the engagement of the government in certain processes, service delivery platforms and ecosystem, that has sort of a trust factor lying behind it. So if you have the government come in, and if you see that the likes of the different donors that have been working in development programs for decades now, those things have trust levels among people. So if the people see that the government is behind this, and there are donors that are behind this, then this sort of brings in an ecosystem and a network of, on one side, financial providers that are able to come into the network, and then the sort of pooled funding approaches, and then connecting these pooled funding approaches to different service providers. And that service provider portfolio needs to include both the public and the private. The public is mostly subsidized, obviously, yes, but in many cases, there are hidden charges in the public sector as well, because of the lack of capacities and different kinds of, like, the governance issues. There are gaps in the public sector service delivery, primary healthcare as well. So once those gaps start getting filled up, and some of those gaps are sort of covered with the vibrant and very strong private sector in health that can provide some primary healthcare service effectively, given that they receive government patronization and maybe a support from a platform that is supported both by the government and also donors. I think this can come together in sort of creating a comfort level for the private sector who provide services, and also for the people who will be availing those services. And then when these sort of ecosystems come into place, there needs to be some pilots that needs to be successful. And those pilots need to be not only driven in isolation by a private firm or a separate donor funded thing. It has to be endorsed by the government, because sustainability is key in this at this point. Unless and until that happens, things will not stand, because we will probably then see that things start falling off in 3-4 years time. So we don't want that. Anything we do, we have to be sustainable. There's a lot of focus and discussion right now around reducing donor funding at this point. So that's an issue that we need to be aware of. We need to create sustainable efforts. We need to bring in private sector investments. We need to mobilize finance from the private sector so that becomes kind of a robust, sustainable model for countries like Bangladesh. And I think these South to South collaborations in terms of sharing ideas and models among countries. When we have 5 countries here that are at 5 levels of maturity, I think this can work wonders if we can bring all of those people in forums and then have those discussions with the governments. Even at the government to government level, those discussions can happen. And maybe some of these regional forums and conferences that we have, if we can have the government people present there from different countries, there can be learning, sharing, and then we can take it up from there. Thank you.
Dr. Fida, that's the perfect point, and the point that I was actually going to ask maybe Dr. Pankaj to comment on. As I understand it from my colleagues, and please correct me if I get this wrong, that India is now positioning itself to be able to share some of the transformation that it is doing, both on the healthcare end as well as the UPI end. Is this something, just exactly the call that Dr. Fida is making? You see India and other countries being able to come together and overcome some of the challenges and mistakes, learn from each other, and accelerate their process of transformation as well. So Dr. Pankaj, I'm going to give you the final word because I know we're going to wrap up soon, but would love to get your thoughts on this.
Sure, thanks, Sejal. So absolutely, what India has done in fintech from a UPI perspective, what now is being attempted in the health tech space through the universal health coverage and the UHI perspective. So, there is UHI as unified health interface to bring all the different components of health tech together. There's a health claim exchange, ACCESS platform that is being launched for health insurance to bring all the different health insurance components together. All of this is open source. So Government of India has said, all the building blocks and all the standards and everything are declared in open source by design. And it is declared in open source so that the collaborative nature of evolving these standards and frameworks can fall into place. So whatever India has done can be used by all the friendly countries, can be adopted by all the friendly countries, and India would like to work with all these countries for implementation of these standards and frameworks, and even evolve it further. So, just to elaborate on what is going on here. So India is moving from 3% of India's population covered by private health insurance and 10% by the government health insurance to about 53% of India's population being covered by some sort of health insurance, with the universal health coverage coming into being. And also going forward, there is a talk about covering the missing middle, which is the OPD insurance for the middle income group. So that sort of takes a quantum jump to from a small percentage of population covered by health insurance to almost like 70% plus population covered by health insurance. And then there is a health wallet kind of a model that is emerging. And then, there is an opportunity to bundle all the different e-claims, e-prescription, e-referrals, those sort of transactions into a health wallet. And so some of the early signs of that are beginning to emerge. For example, Paytm is APDM integrated, APDM being the Ayushman Bharat Digital Mission. So Paytm has put together a PHR app together with their Fintech app. Then Swiss Re has bought a stake into Paytm. Bajaj Finserv, Edelweiss, Aditya Birla, some of the early adopters of building the health wallet, which has the fintech and the health tech component built into the same platform. Pristine Care has acquired Liberate, which is an primary care OPD, and then Pristine Care has already become a unicorn in that sense. So it lays the ground for creating a microfinance and group insurance model. You could go ahead and build a group insurance for villages. An entire village or a group of villages could be brought in on platforms like these, and group health insurance can be rolled out for them. Once you do that, the next step is to start doing disease management. Then you have all the data for early intervention in diseases. You can catch the disease early, you can slow down the disease progression, and you can hope to reduce the burden on the secondary and the tertiary care. It doesn't stop there. You can also do resource optimization and epidemiology research. So a whole plethora of different avenues opened up, and that will require a lot of collaboration, not just restricted to India, but this entire region. And a lot of other friendly countries have to come together to because that's a data play, and more the data, the more the value.
Excellent. That's an excellent point to, I think, end the panel discussion. I want to thank all of our panelists for joining. It was a very rich discussion. I'm going to turn it back to Sireesha to close off our session today. Thank you very much, everybody.
Thank you so much, Sejal, for the moderation, and thank you so much for all the panelists. This has been wonderful discussion, and really appreciate all your time here today, answering all the questions, and also having a brainstorming, rather than, I would say that all these pathways or the discussions have led to understand that these opportunities are for knowledge exchange and sharing across the stakeholder groups, both public and private. And as one of our participants have, Daryl, he says, and I could not agree more, that the wider acceptance of any healthcare would require both the government and the private sector to collaborate at some point. And I think it's a starting for us in terms of looking at what innovations come along the way, in terms of how this can take up to the next level of financial inclusion, ensuring that we have less out-of-pocket expenditure and financial protection for all in every country. With that, I would like to close this webinar today, and thank you so much, everyone, for your time today. Really appreciate your time.
Thank you.